Sorry, Dr. Hassel. That is Kahoot, but it had to be done. Okay, so first question. Patient presents to the ED with muscle aches and dark urine after running. What would you expect to see in his urine? Okay. So this patient is presenting with rhabdo. Just as a review, rhabdo occurs due to muscle necrosis, and then release of intracellular enzymes and electrolytes is what leads to its complications. Patients usually present with muscle pain, weakness, and dark urine. So on urinalysis, you shouldn't see any infectious signs. So you're not going to see any leukocyte esterase or white blood cells. You will see 3+ blood because the urine analyzer misinterprets both myoglobin and hemoglobin as heme and therefore as blood. But on microscopic analysis, you shouldn't see any red blood cells. And then there will be tubular casts. And serum CK levels in rhabdo are usually 5 times the upper limit of normal. And then complications are hyperkalemia, hyperphosphatemia, hypocalcemia. You can get hypovolemia because of third spacing. The fluid goes into the injured muscle, and this can increase the risk of AKI further. You can also have hyperuricemia, metabolic acidosis. Severe cases can lead to DIC, seizures, and death. So our next question. Good job for Ross. What is the most common cause of common bacterial cause of complicated UTI? Okay, so E. coli is the most common cause of both uncomplicated and complicated UTIs. This is because of the proximity of the bacteria to the urethra. And organisms of the UTI are usually dependent on the host. So for example, patients who are getting a urologic procedure, most common organism in that case could be Pseudomonas. In young females, sometimes a common organism is Staph saprophyticus if they have pyelo. And just as a review for complicated UTI, these are patients who have systemic signs and symptoms of infection, so fever, blood hypotension, tachycardia, they have CVA tenderness, flank pain, and risk factors for complicated UTI include abnormal urinary tract, functional or anatomic abnormality, infection with comorbidities, neurogenic bladder, stents, neonates, immunosuppression, pregnancy, things like that. 38-year-old with ESRD on dialysis presents with itchy scalp. What is associated with the same underlying physiology? Yeah, so does anybody know what that is called? That was in the picture? Yeah. So it's a severe manifestation of severe uremia. Usually presents when patients sweat and that sweat evaporates. They have crystals left over on their skin. It's very rare to see that in a developed nation since we have hemodialysis, but if you're working somewhere remote, it's a sign that somebody is in severe renal failure. you have limited resources, you can use that as a clue to make the diagnosis. And then some other complications are pericarditis, seizures, encephalopathy, platelet dysfunction, and bleeding. Okay. What are the diagnostic criteria for infectious peritonitis in patients who receive peritoneal dialysis? So the answer is greater than 100,000 WBCs and greater than 50%. Wait. What? Yeah, the and in the or. So there's always some inflammation present in patients with peritoneal dialysis. So the cutoff values are pretty high. Greater than 100,000 WBCs and greater than 50% neutrophils is diagnostic, as well as a positive culture. Most common organisms are those that are found on the skin, so Staph aureus, Staph epidermidis, or strep. And these patients usually present with abdominal pain, tenderness, and cloudy dialysate.
I say if you have a high index of suspicion, regardless of the lab, you should emphasize treatment.
Mm-hmm.
Same thing as SBP.
Mm-hmm. What is the primary reason gadolinium contrast is contraindicated in ESRD on dialysis? So patients with ESRD on dialysis, if they are given gadolinium contrast, they're at risk for nephrogenic systemic sclerosis. This can happen at any point after dialysis. In certain instances, it was found 10 years after the patient got an MRI. They present with thickened skin, nodules, severe itching, hyperpigmentation. They can get contractures over the joints. It can be very debilitating and people can become wheelchair bound. It can lead to sclerosing of and fibrosis of certain organs, and it is a progressive disease that can lead to death. But there have been cases that have been self-resolving. It's a fairly new disease. So there's not much that is known about it, but it's thought to involve circulating fibrocytes that are stimulated by gadolinium. And patients who get a biopsy of the skin findings, gadolinium is found within that biopsy. Toxicity of which of the following can be treated with hemodialysis? Okay, so carbamazepine. So there are three main factors that influence the dialysability of something, and that's molecular weight, protein binding ability, and a volume of distribution. So dialysis is usually ineffective with compounds that have larger molecular weights, large volume of distribution, and are protein bound. So other examples of dialysable compounds that we spoke about before are lithium, aspirin, theophylline, the ethylene glycol and methanol, as well as metformin. So for carbamazepine, It has pretty severe side effects, which include Stevens-Johnson syndrome. It can lead to hypertonicity, nervous system depression, serum levels greater than 40 are associated at increased risk of respiratory failure, seizures, cardiac conduction abnormalities, and coma. And so in these patients, you would think to dialyze them if they have greater than 40. And then some other indications for dialysis, just as a review, is acidosis, usually pH less than 7.1. Electrolyte abnormalities, so hyperkalemia that's refractory to treatment or rapidly rising. Ingestions we spoke about, volume overload, and uremia with signs of uremic bleeding, pericarditis, encephalopathy, and neuropathy. Which of the following symptoms is the most common presentation of urinary bladder cancer? Oh, nice. Gross painless hematuria, yeah. So the most common urinary bladder cancer is transitional cell carcinoma, and hematuria is the most common presenting symptom of it. In any patients who are over the age of 40 who present to the ED with painless hematuria, bladder cancer needs to be ruled out, so they need to be followed up with urology. And just to review, risk factors for bladder cancer include cigarette smoking, alanine, dyes, solvents, arsenic exposure, patients who have chronic cystitis, schistosomiasis, radiation, and cyclophosphamide use. A nursing home patient with AMS has AKI with BUN creatinine of 75 to 5, which is most likely to be elicited on history or physical exam. Urinary retention. So just a quick review using BUN creatinine ratios. If the ratio is less than 10 to 1, it's usually suggestive of an intrinsic renal failure because you're not able to reabsorb that BUN because your kidneys aren't functioning. In post-obstructive renal failure, it's usually 10 to 20 to 1. And then in pre-renal failure, it's greater than 20 to 1 because you are able to reabsorb that BUN and your kidneys are trying to preserve volume even though you're hypovolemic. So in this case, it's urinary retention. What initial steps should be taken to control dialysis excess bleeding? Yep, direct pressure. So dialysis excess bleeding is considered an arterial bleed. We actually had a case with Dawn and CCT a few days ago with a patient who came in with towels just soaked with blood from the dialysis center, and she still had some bleeding. So basically, we held pressure for several minutes. Usually it's recommended 5 to 10 minutes, hold pressure, and then you should observe the patient in the ED for a few hours just to make sure the bleed doesn't recur. And in that case, we also used Surgicel. You can use a figure-of-8 stitch. You can consult vascular surgery, but the most important thing is to hold pressure.
So it's leading to that. So occasionally the axis just blows and you have to stop the bleeding. Direct pressure from the top of the nerve, and usually put the blood pressure cuff above the axis and blow it up. Use it as a tourniquet to control bleeding. If access has a big hole in it and they're pouring out blood,
Right.
then you have to tie the access off. And you can do it with all both, but you have to tie both sides,
Okay.
the arterial and the venous side. On either side of the puncture, you have to tie the access off because remember, it's an AV access.
Mhm.
So if you just tie one side off, it'll just bleed from the other side.
Mhm.
So in case you're at a center where you don't have surgeons like we have, nowadays we just call the surgical doctors to come down by the catheter, but if you're in a small ED and the patient bleeds to death, you put on the blood pressure pump as a tourniquet, stop the bleeding, and then tie off the access on both sides of the hole.
Mhm. Okay.
I would suggest to use the tourniquet even before you assess what's going on. So open tourniquet, open up the bandage, and then slowly undo it to see what's actually happening.
Yep. We did do that. I just forgot.
Most
Sorry.
bleeding from the access is that it's not this gigantic arterial bleeding pouring out, it's just a little oozing at the site.
Yeah.
And that's because blood has got under the skin and it's just coming out from the hole. So you could just put a suture at the hole and the blood will reabsorb under the skin.
Mhm.
You could send the patient home.
Just remember, if you have surgery, then they should do it, not you. If you go too deep and you get part of the fistula in there, you're gonna restrict flow, you're gonna cause problems.
Okay.
So if you have a surgeon there, let them do it. But if you're forced, then just be super careful not to tie off the fistula.
Okay.
You're turning the bulb, right?
Yeah. Yeah.
Always trying to get above the lesion.
Mhm.
Proximal control.
Yeah.
So just for those who didn't hear, if it's a large bleed, you're going to put a tourniquet. You can use a blood pressure cuff above the fistula site, and surgery should be doing the stitch if they're there. So we're almost done. Peritoneal dialysis has cloudy effluent. Which of the following is the most appropriate management for this condition? So this is peritonitis, most common complication in a patient receiving peritoneal dialysis. And treatment is usually outpatient management with intraperitoneal antibiotics. Oral won't work. Very rarely would you admit somebody for this, and only in cases of signs of systemic infection. So fever, if the patient is unstable, hypotensive. So almost all cases are treated on an outpatient basis, and patients are given either first generation cephalosporin or vancomycin and gentamicin. And most common organisms, again, are those that are on the skin. So Staph aureus, Staph epidermidis, sometimes enteric gram-negative organisms.
It's a complicated formula and mixing up the antibiotics with the peritoneal fluid. So this is not for us to do. It's not just the normal antibiotics. You hook it up with the peritoneal catheter. Renal has to.
Mm-hmm. So if you have a patient with peritonitis, consult renal because they have to figure out the antibiotics and dosing. And 28-year-old male with 2 new sexual partners has dysuria. UA shows 2 white blood cells plus 1 bacteria. Which antibiotic regimen is most appropriate? Correct. So in young males, this patient is presenting with urethritis. In young males with urethritis, you should suspect an STI until proven otherwise. So you should, for the most part, always treat for STI. And new guidelines are ceftriaxone 500 milligrams IM and doxy 100 milligrams BID for 7 days. That's for males and females.
If the patient is more than 300 pounds and the ceftriaxone dose is a gram, it's 1,000 milligrams.
Yeah, if the patient is more than 300 pounds, it's a gram of ceftriaxone. And then I think it can be given as 2 shots because a gram is,
very painful.
yeah.
And if, in fact, even, it's a good idea when you give ceftriaxone to mix with lidocaine.
Mm-hmm.
No doxing pregnancy.
No doxing.
Yes, if they're pregnant, you have to use
Would be
it as well.
azithromycin.
Maybe not as good, but it's the only alternative we have.
That is all.
Very good. But you'll send out all the answers, right?
Yeah,
To
yep.
the residents.
Definitely.
We have a topic review next week, it's on endocrine.